All right, go to the next slide. Welcome. We are here for our knowledge, Liberation of Knowledge Prayojana series. Today we have Dr. Salahuddin Halasa, who's an innovator, has a global perspective on COVID-19 with cross-disciplinary expertise, have integrative medicine background, and also some pioneering innovations that he has created. Additionally, we have Dr. Joyce Grossman, who is a medical doctor who is in infectious disease, internal medicine, and pediatric specialties, in addition to have 3 different masters in cell biology, biochemistry, immunology, and genetics. We have Dr. Arasawa Okesanya, who's a physician, family medicine, who is in virtual care and also frontline COVID, who's going to be moderating the session. And Juby George-Vaze, it's brought to you by Globex Health. We have a small disclaimer. Can you just go to the next slide? So this is information only. We are not offering medical advice. There's going to be a lot of shifting information going on inside the space of COVID. And a lot of the resources you can find will be in the next slide, which is World Health Organization, the Association for Different Governors. If you can go to the next slide, Dr. Halasa. And then I'm going to pass this over to Dr. Halasa, but I forgot to introduce one other person. That's Dr. Mike Bogmeyer, who's also going to be presenting in conjunction with Dr. Halasa, who will be doing majority of the next session, has an interesting perspective on some of the treatments and medicinal properties and what's being used. And he's a pharmacist by training. Go ahead, Dr. Halasa. I'm handing this over to you.
Okay, clear. Good. Hi, everybody. And yeah, we're going to talk about COVID-19, pathophysiology, and we're going to talk about some of the management of COVID-19 and the current status of COVID-19. As you see, it's getting worse, especially here in the United States, comparing to other countries. And I think it's because of maybe the ignorance that we have in following the guidelines. But I think people need to go back to the guidelines. Social distancing and wearing the mask, especially in the area of closed spaces like in the stores and airport. All of this areas needs to be. We need all to be wearing the mask, especially covering the mouth as a source of infection. We're going to talk about COVID-19 versus previous coronaviruses and what's the difference between them. We know that the common cold is caused by coronaviruses, but they are different from the COVID-19 in terms that the previous coronaviruses or common cold viruses does not really interfere with main physiology of our bodies. But the COVID-19, it does interfere with the physiology. It does interfere with the RAS system, which we're going to talk about, the renin-angiotensin system, leads to overactivation of the RAS system and causing what we call the cytokine storm. And we're going to see that in the coming slides. So we will see that this virus do infect all the cells that carry Ac2 receptors. So it's in fact Ac2 receptors positive cells. It's equivalent to HIV. HIV viruses does interfere with acquired immunity by infecting all the CD4 positive cells and causing immune suppression and interfere with acquired immunity. But the COVID-19 does interfere with the innate immunity by overactivation of the RAS system through blocking the ACE2 receptor. So we're going to see that in the coming slide, the comparison between the common cold, the previous coronaviruses versus the COVID-19 viruses. As you see here in common cold viruses, which is one of the coronaviruses, 2022-9E, when they infect the lining of the epithelium of the respiratory tract, they attach to a receptor which is called here aminopeptide N. And really, aminopeptide N does not have any significant function in the cell. So it does not interfere with any major physiology of our body, except it is the entry point where it gets inside the cells, and what will happen, this will trigger the inflammation. Of course, the virus will be replicating, and the immune system, the innate immune system will will generate pro-inflammatory cytokines and free radicals, and this will activate the RAS system, which is the renin-angiotensin system, right? And when you activate the renin-angiotensin system, you will end up with converting angiotensinogen into angiotensin 1 in the liver, and then angiotensin 1 to angiotensin 2 in the lung, right? And then what will happen is that the inflammation and the free radicals will express the angiotensin 1 receptor, and the angiotensin 1 receptor, as you see it here, they will block the ACE2 receptor. All right, so this is the process that's going to happen. And when it blocks the ACE2 receptor, what will happen, the angiotensin 1 receptor will pick up the angiotensin 2, and it will signal the inflammatory process. It will activate the NOX enzyme, and NOX enzyme will generate the free radicals, and this leads to induction or signaling the whole inflammatory process, which is very important in order to destroy the virus. So when you have, when the body is being infected with this common cold virus, you have the inflammation. Inflammation is very important. The RAS system will be activated. The angiotensin 1 receptor will be activated by angiotensin 2. It will block the ACE2 receptor enzyme. And yes, we need that inflammation, that initial inflammation, the free radicals that we needed to destroy the virus, right? And then what would happen is, after the inflammation, it will be over, and then we will have what the anti-inflammatory process will be kicked on. And as you see it here, the free radicals will activate the NOS enzyme, which is nitric oxide synthase enzyme. And then the nitric oxide synthase enzyme will activate the angiotensin 2 receptor. And then angiotensin 2 receptor will do the opposite of what angiotensin 1 receptor, which is activating the angiotensin converting enzyme, as you see it here, the ACE2 receptor, right? And the ACE2 receptor was being active, it will convert the angiotensin 2, right, into angiotensin 1,7, and then angiotensin 1,7 will activate the MAS receptor, and the MAS receptor, when it's being activated, it will activate the antioxidants, it will activate the anti-inflammatory cytokines, it will activate the anti-apoptotic signals, the anti-fibrotic signals, right, and will block the NOX enzyme and reduce the free radicals. So this leads to an anti-inflammatory effect, which is very important so we can start the healing. So this is what's happening during the infection with common cold. You would have inflammation start first, and then you will have the anti-inflammatory arm of the RAS system will be activated, and that will lead to the healing and anti-inflammatory effect and the immune homeostasis. And this is the normal process to fight infection. We need first inflammation, killing the virus, and that was mediated by angiotensin 1 receptor. And then we need the anti-inflammatory effect, the anti-inflammatory arm of the RAS system to be activated, which is angiotensin 2 receptor. And when they activate it, they will activate the ACE2 receptor, and ACE2 receptor will convert angiotensin 2 to angiotensin 1,7, which will activate the MAS receptor, and the MAS receptor will activate the NOS enzyme, generate nitric oxide. The nitric oxide will stimulate more of angiotensin 2 receptor and causing what? The activation of more of ACE2 receptor, more of anti-inflammatory signal, more of anti-apoptotic signal, anti-fibrotic signal, and that leads to the healing effect that we need, and the immune balance and the adaptive immunity. So this is what's happening during common cold. But what would happen with Sars virus? It's a little bit different. they don't really combine with a regular receptor, does not have significant function as we see in the common cold virus. This virus combined and interfere and block with essential enzyme of the RAS system, which is the Ac2 receptor. And Ac2 receptor is a very important enzyme because it's an enzyme that will convert angiotensin 2 to angiotensin 1 and 7 and kicks the anti-inflammatory effect. So if you block that, you block the arm of anti-inflammatory. So you will have unchecked inflammatory arm of the RAS system, right? And you will have over-inflammation, you will have cytokine storm, and that's what we're gonna see in the coming slide. So here the virus is attaching to the Ac2 receptor, and it's getting in and it's causing inflammation, and it's causing all these free radicals that's being generated. And what will happen when those free radicals being generated, it will overexpress the angiotensin 1 receptor. The angiotensin 1 receptor will block the Ac2 receptor as you see it here, and they will take the angiotensin 2. Once they combine with angiotensin 2, they will signal the anti-inflammatory effect, anti-inflammatory signals, which is activation of NOX enzyme. NOX enzyme will produce the free radicals, right? And as you see here, those free radicals will stimulate the expression of angiotensin 1 receptor. So you have this vicious circle of overproduction of the reactive oxygen species and overexpression of angiotensin 1 receptor and overexpression of pro-inflammatory cytokines, right? And so, yes, the reactive oxygen species will stimulate the NOS enzyme and will produce nitric oxide, but the problem we have is too much of free radicals will neutralize the nitric oxide, will not allow the nitric oxide to express the angiotensin 2 receptor. So the angiotensin 2 receptor will not be expressed. The Ac2 receptor is being blocked by the virus, which means that the anti-inflammatory arm of the RAS system is completely blocked, which means that the inflammatory arm of the RAS system is unchecked, overactive, producing too much of reactive oxygen species, which will lead to an inflammatory cytokines, will stimulate those white blood cells to secrete and overproduce or overexpress inflammatory cytokines and lead to cytokine storm. And that's not the problem that we have with COVID-19. It interferes with the physiology of the RAS system. As you see in the previous slide, in the common cold virus, we have first the inflammation followed by anti-inflammatory. In COVID-19, the anti-inflammatory arm is being blocked because this virus blocks the Ac2 receptor, which is very essential to convert the angiotensin 2 to angiotensin 1 and 7, activate the MAS system. So this is not in case of the COVID-19.
So Dr. Halasa, you know what, I mean, this is great. I mean, I think this is just taking me back to Biochem 101. But, you know, and I think it's kind of fascinating because, you know, do we really get a sense of why the virus acts like so? Like, why is it so different? I mean, and Dr. Grossman, do you have
well, I mean, what I just wanted to ask was, it appears that the cytokine storm is most severe in children. And in fact, the syndrome that's produced is very similar to Kawasaki disease, which actually I had seen when I was at Kings County before anybody knew anything about this. And it seemed to be a post-viral syndrome. And the effects of it are exactly the same. You get swollen feet, prolonged fever, you get red mouth and tongue. It's really, really very, very outstanding. I mean, when you see it, you don't forget it. And I was just wondering whether or not it's the fact that children's immune system is still developing and is still different than adults, that we have such a pro-cytokine storm that in older people, it's not as severe.
This process happens on every age, whether you're young or elderly. This is the process. This is the pathophysiology of COVID-19 in general. Now, if those kids, they have genetic SNPs, they've been infected with certain trait, or they've been exposed to high dose of the virus to the point where their endothelial of their blood vessels are all infected, and they will have endothelitis, and that's the reason why they have the Kawasaki syndrome. That's what's happening for those kids. But also the elderly, they may have the cytokine storm, and the endothelium will be infected, but they will have what we call it, because endothelium, when they're infected, and you will have endothelial dysfunction, you will have less production of nitric oxide, which is very important to keep the blood thin, because nitric oxide does have antiplatelets effect, and that leads to stroke and death in the elderly. So it really, there's many factors determine the severity of the COVID-19 from one patient to another. And we talked about those 4 factors. One is the viral load that's been first exposed to, and the second is the trait of the virus. Third is underlying disease, and then the genetic SNPs of the
host. Yeah.
But this is what's happening generally for. This is the pathophysiology of COVID-19 in general.
No, it's very interesting. It really is, and the virus causes a lot of things that I have never seen. For example, people can pass out. I mean, they think they're okay, and then they pass out, and then they're found to be very hypoxic, and they have multiple pulmonary emboli. Any patient that I've seen, either in adults or children, when they had pulmonary emboli, they were short of breath, they were struggling, and it was a whole syndrome, which it appears when this virus infects someone who has a predisposition for that, because it doesn't happen to everybody. I mean, they seem to be totally unaffected, but yet they're severely hypoxic, and they'll pass out and then die shortly afterwards.
Right. So that's where, as I said, there's 4 factors. The viral overload, really, it does not, yes, other factors will be part of it, but if you expose, even if you're a healthy person, especially the healthcare providers, and because of their job being exposed to patients who are COVID-19, it will add up. And they're wearing their mask, and they're rebreathing the virus again and again. So those healthcare providers are high risk of getting the high dose of the virus, and that can cause can impact the severity of COVID-19 and cause all the complications of the COVID-19 as you see there. So even if you're healthy, even if you don't have genetic SNPs, even if the trait is not that severe, but you have a high viral load exposure, you may end up with the highest, the severity of the disease and the cytokine storm and the endothelitis and the coagulability and those doctors that are dying. So that's the reason healthcare providers are the high risk individual in this pandemic, and they need to be taking care and giving them all the resources for protection, because they are the vulnerable people there, even if they don't have any underlying diseases.
No, I agree with you. I think all the information we get shows that, because they're young, healthy people who get overwhelmed by this virus.
Exactly. So let me continue, and then we're going to talk about how this is causing the disease here. But we understand that this virus, it's equivalent to HIV. HIV affects the CD4 positive cells, lymphocytes, and it causes acquired immune deficiency. This virus infects Ac2 receptor, and it will cause imbalance in the innate immunity, where you will have overactivation of the angiotensin 1 receptor arm, which of the renin system, and leads to this pro-inflammatory cytokines. It leads to pro-oxidant overproduction. It leads to apoptotic signaling. It leads to fibrosis. And so this overactive unchecked arm of the inflammation, because the Ac2 receptor is being blocked, which is very important enzyme that convert the angiotensin 2 to angiotensin 1,7, which will stimulate the antioxidant signal, anti-inflammatory signal. So it's being blocked. So think about it, you're pressing on the gas with no brakes. This is what's happening. So you have too much of inflammation, and it's immune compromised, innate immune compromised. It's equivalent to what's happening to the acquired immunity here. As you see here, even the nitric oxide that's being produced, it will react with the free radicals, those overproduced free radicals. So this nitric oxide cannot really stimulate the expression of the angiotensin 1 receptor, which is the anti-inflammatory arm. And as you see here, you will not have the immune homeostasis or adaptive immunity that we have for the normal, the coronaviruses that we previously getting, which is the common cold. So it's completely different. And the other thing is that, so we will find out what is the Ac2 receptor cells, the respiratory epithelium that lines the respiratory tract. They are Ac2 receptor cells, the pneumocytes that lines the alveoli, and also the endothelium that lines the capillaries. So if you see this virus is different from, common cold viruses. The common cold virus does affect the pneumocytes and the epithelium that lines the respiratory tract. But this virus also infects the capillaries that surround the alveoli. So think about it, you have a damage in the pneumocytes of the alveoli and damage in the capillaries that surround it. So you have both wall is being damaged, which leads to acute respiratory distress syndrome, and it leads to all this cytokine storm, and you'll see the X-ray of those patients are completely like a glass. Why? Because it's not just pneumocyte or inflammation of pneumocytes that line the alveoli. It is also the capillary, the endothelites that affecting the capillary. So you have all these walls being damaged completely and leaking out the fluid, and leads to all this congestions and very clear, and it's very and so is this more of vasculites versus pneumocytes? I think it's more even vasculites, this disease, and eventually if the virus is replicating and it's increasing in number, it can affect other endothelial blood vessels of other organs, including the heart, the brain, and you will get this encephalitis, you will get the myocarditis, you will get some gastroenteritis. So you get inflammation due to this endothelium that lines the capillaries of all these organs. So it's a multi-organ disease. If the disease is progressing and there is nothing is holding on those fires, and you're not receiving the right treatment, which we are going to discuss it here in this slide. So who is at high risk of having complications of COVID-19 are all the patients with abnormal endothelial function. So how I can screen people who are vulnerable versus non-vulnerable, really we can do that simply by testing the endothelial function test. And if we go back to the people who are vulnerable, we find out the people with obesity, people with diabetic, cardiovascular disease, and the common dominator among all those three conditions is endothelial dysfunction. All of them, they have abnormal endothelial dysfunction. So, abnormal dysfunction, endothelial dysfunction. So basically, we can screen the patients now. We can say, okay, so let's go ahead and screen them. If you have abnormal endothelial dysfunction, you have a high risk of getting COVID-19 complication. If you have a healthy endothelial function, you have a good production of nitric oxide, because nitric oxide is an antiviral agent, very important in killing the virus. And also it helps to thin the blood, preventing the coagulation. So if you have endothelial dysfunction at the start and the virus is infecting your endothelial, this leads to further endothelial dysfunction, further decrease of the nitric oxide. It will compromise the innate immunity, which is nitric oxide itself is part of the innate immunity. It helps to protect you from the virus, but also it helps to thin the blood. So those people, they have high risk of coagulability and stroke and all these complications of COVID-19. So basically, as you see here.
Dr. Halasa, so sorry. You know what, I actually wanted to ask a question. So I think maybe you're going to get to this. I mean, I know you've kind of mentioned that, okay, endothelial, I guess endothelial, kind of making sure endothelial weakness or not.
Dysfunction, yes.
Yeah, dysfunction, kind of a setting. How exactly do we want to measure that? Is that something we're kind of coming to? Because I mean, we understand that, yeah, there's some diseases to a certain extent will have this kind of dysfunction. The question is, how can we really quantify that to give us a sense of who's really going to be at risk?
So there is already a company out there manufacturing endothelial dysfunction, an endothelial function test. It's billable by insurance. An endothelial function test, I consider it as a stethoscope of the integrative doctor. If you're an integrative doctor, you don't have endothelial function test. It's like a family physician without stethoscope, because endothelial cells are they are very sensitive to free radicals, to the oxidative stress. So if you have a patient with obesity, diabetes, hypertension, all of them, they have endothelial dysfunction. Those free radicals being generated because of these diseases, it does damage the endothelial cells that lines the blood vessels. And there's a test out there to tell you that this patient has endothelial dysfunction. Okay, so when you do all your integrative approach, 6-hormone, peptide, detox, name it, you're giving the patient microbiome to fix the leaky gut syndrome. What you're doing ultimately, you're restoring the nitrox balance. And when you restore the nitrox balance, you are decreasing the oxidation damage of the endothelium, you're improving the endothelium function. And then that test that you do before and after your treatment shows that all your endothelium is improving. Yes, your 6-hormone is working, your peptide is working, your microbiome is working, your detox is working, your exosomes are working, all the integrative approach that we are doing, and the ultimate effect is restoring the nitrox balance and restoring the endothelial function.
Hi, this is Dr. Grossman. I have a question. I mean, I understand the endothelial dysfunction. If you have an elderly population, what's the probability that they don't have endothelial dysfunction?
All of them.
And they don't have increased free radical accumulation? Because with aging, I mean, it's sort of a normal part of aging that these things accumulate, and that's why the elderly have the problems they do.
Right. So the elderly people, they will have endothelial dysfunction. And that's the reason why, if the elderly people, we start managing them with all this 6-hormone, detox, microbiome, things that we're doing integratively, antibiotics, restoring all that, you will see their endothelial function test will improve. I'm not saying they will become an excellent. It's part of the aging process. They will be less than the youngsters, but you can improve it. And if you improve it, you minimize the risk of the complication of the COVID-19. So we're using the endothelial function test as a guide, as a diagnostic test for integrative doctors to know whether they're on the right track in restoring the redox balance and managing the oxidative stress, which include all those chronic disease out there.
You know what, I actually have a question here. I think someone kind of posed this, and I think as a bit of a comment, they're saying that the Jackson lab had showed data that discussed antibody levels in the elderly, and then there's also overproduction of antibody, not just in children. So I guess when discussing the vaccine, it's not really evident that using post-COVID serum is going to really work for everyone. So I think there's more a comment to what we're kind of discussing here.
So are you talking about giving this the antibody, the serum, or you're talking about the vaccine?
So they were saying, so what we're thinking about, well, I guess when you're putting a vaccine, you're hoping at least to stimulate the body to make antibodies. And I think what the person is saying is that, well, there seems to be overproduction of antibodies in the elderly as well.
No, the elderly don't overproduce antibodies generally.
Okay.
I mean, but they do get a lot of endothelial dysfunction. Right. I mean, the plasma is just taking people who are overwhelmed, and you're hoping, since you're giving them serum that restores factors that they may be lacking, like antibodies, but it could also be T cells and other factors, which enable them to overcome the illness. I mean, other than that, you're not really restoring them to anything other than, I mean, it's a bridge to getting them to recover.
Right.
So we need to distinguish between vaccine and giving serum. So the one that from the convalescent plasma, so you take recovered patient's blood, take the plasma out of it, definitely this company, they use methylene blue photodynamic therapy to inactivate any germs in the blood or the plasma before they're giving it to the recipient, which is the sick person who needs those antibodies to neutralize their virus. Okay, so it's something that helps those patients who are in the ICU who needs antibodies to neutralize the viruses that they have. So we use this convalescent plasma. This is one. But for vaccine, is basically they take the COVID-19 viruses, they inactivate it with many methods, chemically, radiation. Methylene blue photodynamic therapy is one way of inactivating the virus. And then they take this weak virus, they give it to the patient, so the patient will produce antibodies that will fight the oncoming wild virus that's coming from outside. So other companies, they engineer the vaccine in a certain way. It's chemical engineering the proteins of these viruses and trying to trigger the antibodies to fight the COVID-19 as well. It depends. There's two approach or two methods, engineering proteins or inactivating the virus itself. But the problem with this is that all the COVID coronaviruses vaccine failed in the past. One of them is the lab that we have in China is designed for developing the vaccine. That's why the United States did fund it. But they fail really, and they end up because of the contamination developing even this hybrid virus, which have other genetic traits, traces of HIV and bacteria. I think there's some contamination there, and they're culturing. And I think the reason why people, they don't like vaccine, not because the vaccine itself or the idea of concept of vaccine, but the preparation of the vaccine and the contaminations with other viruses and other germs. That's what they're afraid of. Okay,
that's been a problem for a long time. The initial polio vaccine was contaminated with, I forgot what, with I think it was a simian virus, and they claim that some cancer specimens did have portions of that simian virus in it, and that perhaps the polio vaccine was connected to that. That's always a problem in the preparation of a vaccine. You know, you're not getting pure vaccine. Now, what these companies have tried to do is they're using like mRNA vaccines, and unfortunately, at least until the present, this type of vaccine has never been documented to be able to give really, really strong immunity. So if these viruses really do work, it'd probably be the first time these type of vaccination did that. DNA vaccines haven't worked either.
Right. So we don't have yet reliable vaccine up to now. And even if they develop the vaccine, the problem with this coronavirus is like it changed in its like flu viruses. They change in their shape. So the next year will be different. That's why if you see Dr. Fauci saying, well, you know what, we expected the next year it's going to be worse. Well, when he said that, it's based on this coronavirus is going to change. So even if you develop the vaccine, it will affect the old strain, but it will not affect the new strain. So you need billions of dollars to develop a new one. And when you develop the new one, the virus will change. So I don't think we need to rely on the vaccine. We need to think outside the box. And I think there's two options that we have in front of us is inactivating the virus by using photodynamic therapy. Methylene blue photodynamic therapy is an option. Oral methylene blue photodynamic therapy is the best because we know that the highest viral load in our body, especially for patients with asymptomatic or even symptomatic, is the mouth, salivary glands, and even more than the nasal cavity. The reason why the viral load is more in the mouth than nasal cavity, one, because the Ac2 receptor is more in the mouth than the nasal cavity. The second is that the nasal cavity contains what we call the nasal nitric oxide production. We have a machine a factory of nitric oxide in our nasal cavity, in our sinuses. And they produce nasal nitric oxide that itself is protecting us against infection, including COVID-19 viruses. So it's destroying it, and so we have some protection there. That's why breathing through the nose is very important. Don't breathe through your mouth.
That's why mouth breathers, especially in children, because they have large adenoids and large tonsils, leads to many respiratory infections because they're not breathing through the nose, and that whole system is being bypassed.
Exactly. So it's very important that the nasal has nitric oxide, protect us against germs, including COVID-19. That's why when they start doing the swab from the nasal, it came out much of it false negative. And the reason because this nitric oxide is destroying those viruses, versus the swab from the mouth is more effective. So they switched from nasal to oral. And the other, my kind of proposal here is that I don't think it's reliable for asking people to cover their mouth and nose for a long period of time. Like when I came from Germany in the airplane, it's weird, you know, okay, so they're wearing the mask, it's mandatory, that's fine. But then if you go and you eat, you can go ahead and take off the mask and then you eat. So really doesn't make any sense, right? So another thing is that putting a mask for 10 hours and closing the nose, you will end up with CO2 retention, which can cause confusion and a lot of other complications. You'll be rebreathing the virus, which is not something that's good. So, and because most of the infection really it's because of the saliva drops more than even the nasal air that's coming out from the nose. We know that the nitric oxide is getting protection there. So I think it's more critical to cover your mouth in closed space. I don't have any data to show that covering mouth versus nose. I know that breathing through the nose is better to protect us against COVID-19 because nitric oxide. We know that the viral load is higher in the mouth versus nose, but realistically speaking, people cannot cover their nose for a long period of time. It can be harmful as well, especially the patient with asthma or COPD or cardiovascular. So at least we need to come up with some studies to at least increase the compliance, is to ask the patient to cover their mouth at least. And I think that will be very critical and very important. So we can decrease the viral load. So I'm not also saying that I think we need to get into herd immunity. And Sweden, as you see there, if you go to the death rate in Sweden, it's like one curve, and the death rate is decreasing in Sweden. In the United States, because of the ignorance, and because of the leaders are not actively promoting covering the mask, especially the president. And then you have all these riots and rallies where they are coming out without wearing any mask and without social distancing and all that stuff. So we end up with two curves, and maybe more curves are going to happen. So Sweden is only one curve, and the death rate is decreasing. In the United States, we have two curves, and the second curve is going up. Which indicate every procedure, everything we did, lockdown, all that stuff, it's a waste.
I have a question. In Sweden, how about the elderly, immunocompromised? What do they do? Because we know they're at increased risk. So I could say, yes, the young, healthy people that go out and having a ball in Sweden are getting immunity. But, you know, people of a certain age, that's not going to happen. So what is Sweden doing? Are they locking up their elderly people?
The system of the Sweden is more taking care of their elderly. Possibly they're providing them with all the immune boosting. I'm suggesting that, and they have some sort of isolation. You know.
Yeah, well, that's what I'm saying. They end up in isolation.
And immune boosting. So their diet is better.
Well, what type of immune boosting are they doing?
At least their diet is more healthy than us. They're promoting the good diet in their hospital and their hospice in their area. They may providing better food than what we are providing in our senior hospitals or senior homes. They are well funded. Sweden is a very rich country, and their food are more healthier than what we have here in the United States.
I have some information about that, Dr. Halasa. I actually have a business associate in that area, and they have a whole different healthcare system there. They pay a very high percentage of their income as sales tax, but almost every type of medical procedure that's deemed to be good for people in research is paid for by their health insurance. So they have very good system there with regard to that. And the people see a different way of complying. They have a different pointed out to me by some people that are actually in the biometric device industry, such as what we were talking about at one point earlier today. And they feel that the U.S. may be not ready for that yet because the people don't act in their own best interest in the same way as the people in that country do. And they attribute a lot of their health success to that.
Well, I was wondering then that because, I mean, obesity is associated with a worse outcome in this viral infection. Could it be that, unfortunately, America has a lot of obesity, whereas perhaps Sweden, the elderly are, in better shape?
There are things like that.
You know what? I might want to challenge that because I think, Sweden just decided not to do any social distancing, and they just decided to just kind of continue on with their merry way. And I think it hasn't. I don't know if I would say that's really a success story. I don't think it has borne out that it has been very successful. In fact, their rate of death is definitely higher than ours.
No, that's not true.
Really?
No.
Yeah, that's what I've heard. I've heard them compared to Norway. And Norway, which does...
Sure their rate is higher.
Okay, so here's the thing. If you want to know about the death rate, you count it versus 1 million people. And Sweden are not, maybe this are the 6 or 7 ranking and death rate, and it's dropping, and we are increasing our death rate. So that's not true. So this is the thing about how we can know whether our program is working or not. We measure the death rate per 1 million people, and you can get that in the statistic there. The highest is the United States in death rate per million. And then you have UK, Spain, other countries, and then maybe 6 or 7 is Sweden, and then Germany after that. And then you divide, here's the thing, it's not just enough then, because then you need to divide the death rate over 1 million over the herd immunity. So let's say, for example, if the herd immunity of Sweden is 50%, so there are only 50%, but if the herd immunity is only 10% of Germany and the death rate is equal, let's say, or less, and in Germany, it's still Sweden is better. So you have to divide the death rate over the herd immunity. How much people?
But how are you determining herd immunity?
I would like to challenge that.
Yes.
If I might, sorry. I just looked up on the BBC News a recent article. More than 5,500 people have died with COVID-19 in Sweden, and Sweden only has 10 million people. That's not infected people. So it's one of the highest death rates relative to population size in Europe, and by far the worst among the Nordic nations. So they have not done well. Right. Their curve has flattened, it's true, but this article also talks about them socially distancing at this point.
Okay, so there is a study already, statistic already for that. Just go write down death rate, COVID-19, Google it, okay? You will see it.
I just did Google it. This is from Sweden.
Versus 1 million. Versus
right.
1 million.
Yeah, I think we can do the math.
Yeah, can you do it? Can you go ahead to Google it?
It's 550 per million population. Is that high?
550 per million. How much United States?
That's per million population. That's not infected.
Yeah, per million population.
It's not a death rate. It's not a true death rate. So, in the United States, I have no idea.
Dr. Denard, so that's Dr. Denard, guys. I asked him to just speak up because he had a lot of comments, and I'm like,
sorry.
It's okay.
No problem. I will send you the statistic for that. I have it, and I know that Sweden is not the first. The United States is the first.
We
What was
were
our
just
discussion?
looking at the Johns Hopkins and there's a few other statistics earlier today. Yeah, so the numbers are starting to show as flattening in other countries except in the United States. The testing, number of positive tests are coming back higher. The deaths are actually going down in everywhere, including the United States. The mortality rate is, that is one good news that we have. But that means that one of the topics that downstream that Dr. Halasa is extremely knowledgeable and would bring out is the post-COVID syndrome, people having to live with some of the consequences of COVID that we were not familiar with. Now it's a new wide world that we have to learn to live with. But in the meantime, I believe Dr. Ortel had one or two comments because she led the last 3 sessions. Go ahead, Dr. Ortel. You were mentioning something about I truly lost track of what you were saying.
Okay. Hi, this is Dr. Ortel. And one of the problems with Sweden, if you were elderly and frail, they did not bother to test you, and they have the ability to euthanize, and they were using it a lot. So that actually is turning into a national scandal because of the children being upset that all these parents didn't make it. They weren't tested, they weren't cared for the way we would think one would care for them, and they were just given the injection and that was it. So this is Sweden is kind of I don't think a really good one to look at because we do not euthanize in this country. So the death numbers are going to be different from that.
Right.
If you were sick and frail.
Well, in Germany, they do the same thing anyway. My dad,
Yeah.
they did it on him, so it's not just Sweden.
Guys, that is one of the tragic thing, and Dr. Halasa's father passed away 2 weeks ago, and he just landed from Germany yesterday, and he's doing this today. So I truly want to say thank you for doing this and giving us a first-hand experience from his experience in Europe, in addition to just knowing that how it's done in other parts of the world.
Yeah, but I also want to comment, herd immunity is not, I think, a very good option for a virus that mutates very rapidly, because it's going to be very hard for humans to get herd immunity when it's constantly changing. We haven't done a very good job with flu that's been around for a really long time. It's not a new virus. So I don't know.
But also the vaccine will not work too. So the vaccine, herd immunity is the same category. The question is that, getting infected and getting the antibodies against it, it's even more sound than the vaccine, because the vaccine, you have it for one strain, where herd immunity, it's actually for any strain that's coming up. You got my point?
Well, I think the best way to make a vaccine, which they haven't been able to do for flu yet, is to really target a part of the virus that is essential for that virus's existence. And if you could do that, you could now eradicate that virus.
Right, but up to now, we have no successful vaccines.
That's what I'm saying. We haven't had success. So, right. I mean, it intellectually makes sense, but no one's been able to make it work.
Right.
Dr. Grossman, could I ask you a couple of, one comment I think you're especially positioned to really inform us on is the role of superinfection with COVID or secondary infection. We talked about just kind of looking back at as we talked about the root causes of the pathophysiology. We've talked at times about superinfection or secondary infection and its role in complicating all of this. And I wondered if you had any thoughts on that.
Oh, of course. Yeah. Well, of course, superinfection, I mean, it's classic for the flu. I mean, think about it. You get the flu, and a lot of times it's not the flu that kills you. It's a pneumococcal, bacterial infection that you get from all the secretions. So, I mean, that really is a problem. And as a secondary virus, this virus seems to have the ability to deactivate interferon. So therefore, when you get a viral infection, your body fights it by producing interferon, and this virus laughs at it. So again, it could be a very, very effective superinfection. So that when your body has, let's say I have a flu, and now I get this infection, the COVID-19. Now the COVID-19 is just, is inactivating that interferon, and is really causing a much worse, infection. So yes, it is a very dangerous vaccine in this setting.
Yeah, terrible. The other comment that's very, because we've destroyed two different types of burial. Our barriers. We've destroyed endothelial barrier and we've destroyed pulmonary barrier, right?
Yes. Well, again, that's why this virus appears to be very successful, because it has that ability to do that.
It's amazing. And another point,
all our barriers get destroyed. I mean, it's and that is why it's really raging.
It is. And Dr. Halasa, the other point I wanted to comment on that I think, and thank you, Dr. Grossman, I think that's
no, anytime, no problem.
Very important. The other thing too is mitochondrial dysfunction is also a part of this, because the patient becomes debilitated through mitochondrial dysfunction. And I wanted to point that out as something, so really to make the point is that superinfection or secondary infection and mitochondrial dysfunction compound all of these things that Dr. Halasa has just shown us.
Right, and yes. You have the cytokine storm itself, and too much of free radicals can lead to mitochondrial dysfunction. The other thing, it can lead also to methemoglobinemia. When you have too much of nitric oxide combining with superoxide generating peroxynitrates, then this is very powerful oxidants, and they can oxidize the iron of the hemoglobin from ferrous to ferric, and you will have what sort of methemoglobinemia in combination with acute respiratory distress syndrome, and you will have problem with delivering of the oxygen itself. And that's the reason we think that methylene blue IV is one of the options of treating those patients, because methylene blue has anti-inflammatory, antiviral effect, and also it helps to manage the methemoglobinemia, which is a result of the cytokine storm, all those free radicals that oxidize the hemoglobin. And also, we have a complication of septicemia as well. When you break down all this barrier, the bacteria of the lung will leak outside the lung, and you will have also septicemia. And I think this can lead to septic shock, vasoplesic shock, and the treatment for septic shock and vasoplesic shock is methylene blue IV. So we're going to talk about the treatment in the coming slides here. If you see here that we talked about we can use losartan, one of the options to treat a COVID-19 complication when you have the cytokine storm and you have overactive angiotensin 1 receptor. So what we will do, we need to block the angiotensin 1 receptor. And how we can block that is by using losartan. And how we can deliver it, we can deliver it as tablets, or we can do it by inhalation. There's a company are doing it, working on it, clinical trials on inhaling losartan to block angiotensin 1 receptor. That will block the inflammatory arm of the RAS system, and that would help to decrease the cytokine storm. The other options is CBD. Yes, CBD does have anti-inflammatory effect. It blocks the NOx enzyme. It decreases the free radical production. That's what we need. The third option is nitric oxide inhalation. Nitric oxide, as we know, it's an antiviral. It has antiviral effect. That's why our nasal cavity produce nitric oxide, gives us that protection against the germs. So we can inhale the nitric oxide itself, and nitric oxide will react with the free radical, become peroxynitrate, and destroy those viruses. So nitric oxide inhalation, there's clinical trials of using it to treat this virus as well. And then we also can use methylene blue for the dynamic therapy to inactivate the virus. The methylene blue will react with the RNAs because methylene blue is positive charge, react to negative charge RNAs. And then when you shine the light, it will excite the electrons. It will pick up by the oxygen, generate free radicals, and free radicals will oxidize and damage the RNAs. So photodynamic therapy is one option, using it either oral photodynamic therapy to decrease the viral load of the mouth, because we know the viral load is very high in the mouth. And if the patient is in the stage of cytokine and viremia and a lot of viruses in the body at the end stage, then you can use methylene blue IV and possibly exposing the whole body with red light that helps to activate the methylene blue and destroy the virus. So when you use nitric oxide inhalation, I recommend using also methylene blue, because nitric oxide inhalation can complicate the methemoglobinemia.
Oh, definitely.
That's the reason we need to give the methylene blue IV. And those I'm talking about the critical ill, the severe conditions. I'm not talking about the early stages. Early stages, asymptomatic, just oral methylene blue with immune boosting with melatonin and zinc. I think that will be enough. But then when the patient has started getting more severe, getting mild symptoms to moderate, you may give oral methylene blue tablets. That's fine. Giving some antibiotics, that's okay. Giving low dose steroids, that's when they get into pneumonia. But when they get into cytokine storm, then that's the time when you need to really go and move to losartan inhalation, nitric oxide inhalation, and also methylene blue IV. And then you need to give them also oxygen and other protocols that's being recommended. Is okay if we give them. Again, what's the difference? International management, United States versus Europe. I think the Europeans are more kind of following the guidelines. They respect their scientists. They follow their guidelines. Their presidents are more respectful to their scientists. And they are, so when you go to any store, you have to wear the mask. Outside, they don't wear a mask. But inside, indoors, they wear the mask. Of course, you know, covering the nose for a long period of time is just hard. It's hard for them to be in compliance. So I recommend at least cover the mouth. It's very important in closed space. Why? Because as we know, there's a 4-factor. I mean, yes, there is a factor of the strain, factor of the underlying disease, factor of the steps, and Dr. Ortell is talking about, but also there's factor of viral load. So if you have an indoor, like a store, and you have everybody there is breathing and open their mouth, then you would have viral load in the air, aerosols, and that can lead to enough dose to infect even the healthy people. And they get into the complication of the COVID-19, even if they don't have any underlying diseases. So wearing the mask is very important in indoor state. So why United States versus Europe? Because the United States, as we see that we have ignorance, the rallies without wearing masks, riots without wearing masks. I think that is the cause of the whole problems when we open up. And it caused a spike in the infection. The death rate also definitely will increase. And because I don't think they're following the right protocols to manage the COVID-19. They are following the big pharma, whatever big pharma is dictating for them. But I think the ideal is to immune boost and healthy diet. As much as we can improve the endothelial function, we can prevent the complications of the COVID-19 and inactivate the virus using methylene blue photodynamic therapy, using polyphenols, using vitamin D, zinc, all those things that helps to boost the immune system and improve endothelial function. It is very critical to
Dr. Halasa, I'm just going to interrupt for a second. Dr. Okesanya needs to leave because she has another meeting right now. So I just wanted to thank her for moderating this session, and we'll see her at the next session. If anybody have any questions for Dr. Okesanya, feel free to send it in. At the end of the session, we'll put a slide that shows all the contact information for us.
Okay. Thank you. Thank you, everyone.
Sure.
Thank you.
Thank you.
Even though we are supposed to end at 8 o'clock, we'll extend it another 5 minutes or so that we can cover this area. That's pretty much, what was the hot topic in terms of numbers. So here we go, numbers.
Yeah, the numbers as you see here, the regional daily test and percent of positive 7-day average line, as you see here, things is getting worse. And we have a second curve, as you see there. Maybe it has to do with reopening The US daily death is, you see, this is a two curve. We don't have that in Europe. In Europe, it's only one curve. Now we have a second curve, and that's because of the reopening and not following the guidelines that the Europeans are following. Riots and rallies without wearing masks, and we have the president himself was not proactive wearing masks, so that's the reason we have this problem with the second curve. Again, I can see that there's two curves very clear for the original daily deaths, which indicate that we're not doing good in our management or in our following our guidelines. So Sweden, that's the reason I say Sweden has only one curve. Dr. Ortel, she said, well, the death, you know, all elderly people, they die. I think it's not just Sweden. I think most of Europe is the same. Germany is the same. Like my dad they did not even take care of him. They didn't give him all the resources that he needs because they say he doesn't deserve to live. So you see, but we have here only one curve. That rate is decreasing. So Sweden did not spend that money. And then the herd immunity of Sweden is I think it's more advanced than the rest. So it's very important to divide death rate per million over the herd immunity in order to really assess the management of COVID-19 in the countries. Again, post-COVID-19 syndrome, we know that this virus is infecting the endothelium that lines the blood vessels, and the blood vessels supply all the organs of your body, means that really you will have all these organs damaged, especially if the virus is able to evade the immune system and is replicating, and there's no break on these viruses, then they can cause lung fibrosis. Yes, when after the post-COVID, the damage in the endothelium that lines the blood vessels and can lead to brain damage, encephalitis, muscle damage, myalgic encephalomyelitis. It can lead to confusion. It can lead to chronic fatigue syndrome because of the disturbance in the redox balance because of this chronic inflammation. Possibly, it can kick also some sort of autoimmune or chronic inflammation and imbalance in the cytokines. So how we treat those patients with post-COVID-19 complications, I think methylene blue is an answer for that, and also exosome inhalation. Exosome inhalation, methylene blue, 5 milligram PID, exosome inhalations, I think is the best option to treat all this post-COVID-19. And also myofascial deep release that helps the myofascial massage or release may help also in helping in decreasing the inflammation. And so there's articles about that as well. So depression and anxiety, we can treat that with integrative approach that we are using with balancing the 6 hormones and the vitamins and also giving methylene blue would help the depression as well. Myocarditis inflammation, again, I think is a good option is methylene blue as it has anti-inflammatory effect. It may help the improving the post COVID-19 complication.
So, Dr. Halasa, it's already past 8 o'clock. Do you mind we were going to do this, next section is going to be something that Mike is going to be doing anyway, Dr. Comer. He's going to be presenting next week. Because we're already out of time, we can just take some Q&A at this point, if you don't mind.
Sure. Let's go ahead with that. Yes, please.
Okay. So then, if anybody has any Q&A question to ask or comments to make, please let me know. I'm going to open up the mic for all of you so that you can speak.
Hi, this is Dr. Ortel. Can you tell me is Mike going to talk about how we prescribe methylene blue next week?
Yes.
Okay, great.
Yes, absolutely. And I'll have, I am, a lot of information that can be sent as well along with it.
If anybody wants me to unmute you, please let me know, like raise your hands or something like that inside. I'm trying to unmute as manually as possible. I don't have the ability to unmute all.
I guess I would ask a general question is, do you have any studies on any of the therapies that you've mentioned, including nitric oxide, methylene blue, polyphenols, exosome inhalation, et cetera, that you could cite?
Yes, there will be a list of publications. I think Dr. Mike Beamer is a pharmacist, and the complement of, it will be completely extending this presentation. I was talking about mainly the pathophysiology of COVID-19, but I will let Dr. Mike to present all the evidence of all this treatment. But it's so easy to search that by yourself and just write down nitric oxide, COVID-19, clinical trials, PubMed, and you get the publication there. Methylene blue, the same thing. There are many publications, but it will be recited in the next meeting because we need a pharmacist to do that, which is Mike Beamer, because he's developing all these formulations, and we have all the publication to support anything that we recommend here.
And I also want to apologize. I didn't have time to put in some other resources that because Dr. Halasa was traveling back from Europe, and we just didn't have a lot of time to put this particular series of slides together in a better order. But next week we'll have more of those citations from publishings. There are a lot of them that they have incorporated. Dr. Halasa, would you mind going to the last slide so that we can just put that up as the Q&A?
The last slides. You mean which one?
The end, the last slide. It just says next section.
I think this is the last slide, right? No?
No, one more, a few more. Last slide. Okay. All the way to the end.
This is what Dr. Mike Beamer is going to present next week.
Next week, there are more slides for Mike to present because I took some out.
But this is what he's going to present.
Yes, it is. And this also, this has, so for any of you who is present today who needs more, this has more of those researches and publishing.
Yeah, so here's a publication that Mike Beamer is going to present about methylene blue, and there are many of them.
So
exosomes, right. So
we
this
ran
is
out of time.
Right.
Yeah, so it's the last slide because it just get up. Go back to the last.
Back here.
One more.
Back or forth?
One more. Last slide. Last slide. One more. Back.
Okay.
Back to the last slide. Forward or whatever. The end. The last slide at the end.
You're talking about the end. Here's the end. Here.
Listen, I did it. Crunch time. Yeah, this is it. Thank you.
Okay.
So if you have any questions to anybody in this series, just send the email to this particular email address. It's kind of be collected and distributed and addressed.
My job today is just to talk about the pathophysiology of COVID-19, the management, the publications, the articles will be presented by Dr. Mike Beamer next week. Does that answer your question, Mr. David?
Yeah, that's fine. Thank you.
Sure, anytime.
Does anybody else have any comment or question that I can bring you up to speak, unmute you and ask questions, or you can feel free to type it in. I think there was a question earlier in the session that I didn't get a chance to address. It was, it's something about monoclonal antibody therapy for prophylaxis. Did you guys kind of cover that area, or is it not covered?
Monoclonal antibody for prophylaxis of COVID-19?
Yeah.
And treatment, yeah.
I think, okay, so there's a company, it's called Grifols Company. They are taking plasma from the recovered patients, and then they inactivate all the germs using methylene blue photodynamic therapy, including COVID-19. It's an FDA approval process. You can search this company on the internet. And then they take this plasma after it's been inactivated to contain antibodies of the COVID-19, and they're giving it to sick people in the ICU with severe COVID-19 complications. I don't see that they're giving it to a healthy person to protect them against the virus. That's not the main protocol. It's
you're talking about hyperimmune globulin. I understand. That's like giving somebody gamma globulin, but slightly like it. But no, there are about 5 companies that are they're finding neutralizing antibodies, isolating them, then cloning them, and using them as both passive immunotherapy and immunoprophylaxis. It's a pretty old method. The new part about it is that they can clone these antibodies and select them. David Ho at the Aaron Diamond Center, you know, he's a AIDS icon, is working with Mount Sinai. Lilly's got work on it. Regeneron has 2 non-overlapping antibodies. I personally think that that will be here long before, or a lot before any, you know, conventional type vaccine. And I'm actually looking forward to the introduction of those things.
No, I agree with you. I definitely agree with you.
We just saw that Dr. Ho actually did publish something recently. That
In Nature, yeah.
Yes, you know, and I think he took 5 different patients' antibodies and inactivated them and blended them to whatever it is. And it seemed to work on in vitro, right? It was in vitro.
Yeah, absolutely. They're neutralizing. So I'm actually very excited about that.
But if the strain changes, the COVID-19 change in next year, then those antibodies will not work, right?
Well, you're right. They may not work. They may not work. I think they look for conserved regions if they can. And there may be a multitude of these antibodies that they can combine. So I don't know for sure, but I'm hopeful about it.
How long it lasts in the body?
Typically, the old-fashioned gamma globulin is 3 to 4 weeks, but they can modify the FC portion, you know, the constant region of the immunoglobulin, to make it last much longer. So there's a lot that can be done today that hasn't been done before. And I just find it's not super rocket science. And I think it's something that, you know, we want antibodies in the blood. You know, and there's.
Do you think that will suppress the immune system against getting active immunity when you give them antibodies? No?
I doubt it. I have no idea. You know, I have no idea, but I doubt it. People get, for example, zoster, there's something called ZIG, zoster immune globulin. I think it's given to pregnant women who are exposed to chickenpox. And I've never heard of evidence that it suppresses the immune system. Obviously, they're not sick with anything else. That's one, but that's naturally derived because I don't think it's cloned. You know, and gamma globulin is, I used to do a lot of research on it, I mean, 30 years ago, and I never saw any evidence that it suppressed the immune system.
I believe it probably can, but you'd have to give a lot of it. And, you know, these people, I'm sure, are going to work out so that the right amount is given.
Yeah, and plus you can titrate it, I would imagine.
That's what I'm saying. You could titrate it.
Dr. Dinar, Dr. Ortel had a suggestion. She asked if it's possible for you to kind of present on this topic. You know, this is a 14-part series, so down the line.
Yeah, well, that would be wonderful. I love antibodies.
We have Dr. Poon from Northwell, and we might have Dr. Ho. Actually, I'm going to talk to him because Dr. Grossman knows him. When he was in his early AIDS work, she was somebody that he tapped into for a knowledge base.
Yeah, I'm not an expert. I used to be, I mean, I left medicine years ago. I'm a pathologist who went to Wall Street, basically, but and a bunch of startups. But I used to be a medical reporter. I interviewed Fauci back in the day of HIV, and he's amazingly consistent in his approach to things. And David Ho, I don't know if I interviewed him, but he's remarkable. I think he might have discovered the gene that gives some immunity to natural immunity to HIV. Magic Johnson was his patient. I remember that. So he's great. If you can get him on, yeah. I mean,
Well, it would be lovely. I think maybe since you kind of have a little spare time to dig in a bit, maybe you can think about doing a session on this area that you seem to really have an interest in and knowledge.
Yeah, I mean, it would be good because we could open it up to discussion. I mean, I love antibodies. I think they're very important. I think what happened is in the age of AIDS, T cells just took over.
Yes, well, that's a big issue, is T cell vaccines, or the T cell immune, the innate immunity being stimulated by vaccination for COVID. Because if you want long-term immunity, you think about memory cells, and it's been reported that there is some T cell immunity, some signs of it with both the Moderna vaccine and one other the Oxford vaccine, and maybe the Chinese vaccine, which is good.
Yeah,
but
well, we forget that the immune system works like a dance. It's choreographed. All parts of it work together.
Yeah, no, absolutely, absolutely, and it's complicated. And
it's complicated.
I keep meaning to refresh my knowledge of the innate immune system, but there's a biotech company. I also work with angel companies, and there's a biotech company that is stimulating T cells and then reinfusing them for COVID. And I don't know how far along they are, but it's another approach. It's certainly been done with cancer for a zillion years, with some inconsistent results, but they're getting better. So there's a lot going on, and I think it's all great.
Mm-hmm.
It's all great.
I'll give you a little tidbit here. What if you could inactivate the virus in the body, and the viral load would turn to inactive virus that could be used as a substrate for immunity?
Yeah, no, I understand. Yeah, that makes sense.
Yeah, so I would highly recommend who's interested to attend the next session, because Dr. Mike Boehmer is going to talk about that particular innovation, and these years of research and work done by Dr. Mike and Dr. Halasa and others, but it seemed to have now it has an application in COVID, and inherently the solution is already being used, in the blood product being pulled for COVID and other blood products. So it's actually an FDA approved. It's very interesting that people have not thought about utilizing it. Even when I heard it, when Dr. Grossman heard it, we were all like, oh, now that makes sense. So I would highly recommend that you guys attend the next session. If you have any questions, this is it. I know we always go over. I think I need to start to learn to schedule this with an extra 15 minutes built into it, because we just have such a good conversation and discussion about this that we really appreciate, and we want to stay on. And I want to thank I know the picture is from last session, so it's Dr. Halasa of today, Dr. Halasa for doing the session with us, and Dr. Grossman, and Dr. Okesanya, who left, and then Dr. Mike Boehmer, who contributing into the next session, and obviously Dr. Dinar, who actually was able to also contribute. Thank you very much. And I actually got you into doing a session now. That's even better.
No, you haven't done that, but thank you anyway. I'm flattered.
And thank you also to Dr. Grossman for her esteemed suggestions as well.